Bismillahirrahmanirrahim. Today we are going to discuss esophageal tumors. Esophagus is, we know, that is a long muscular tube that extends from the oropharynx to the cardiac end of the stomach, and at its upper end, the upper esophageal sphincter, and at its junction to the cardiac end of the stomach, the lower esophageal sphincters are located. These two sphincters open during the swallowing and allow the food to enter into the stomach, and the passage of food is facilitated by continuous peristaltic contractions. Now, as we know that the esophagus, it is lined by the squamous epithelium, and on its cross section we can divide histologically the esophagus into four layers. The innermost layer is the mucosa, which is made of squamous epithelial cells, and it is in direct contact with the food, and we know that it gives protection to the inner mucosal lining, and the submucosa, which is made up of squamous epithelial cells, protects the esophageal wall from abrasions by the food. However, it is very sensitive to the acids which is secreted in the stomach, and in conditions in which the acidic gastric contents are regurgitated into the esophagus, they can cause esophageal irritation and inflammation that we see in conditions like the gastroesophageal reflux disorders or GERD and Barrett esophagus, in which the squamous epithelium of the esophagus undergo metaplasia and replaced by the intestinal type of columnar epithelium. The mucosa itself is composed of stratified squamous epithelium, the most inner layer, which lies on the connective tissue layer called the lamina propria, and outside the lamina propria there is muscularis mucosa, which is a muscle layer, but it should not be confused with the muscularis externa, which is the proper muscular layer that consists of inner circular and outer longitudinal muscle fibers, and that cause the contraction of the esophagus to push the food down into the stomach. The two major tumors that arise from the esophageal lining, one is the squamous cell carcinoma, which arises from the squamous epithelium of the esophagus. The other tumor, known as the adenocarcinoma, is actually, it arises from the glandular epithelium, and since the the squamous epithelium of the esophagus is entirely different from the epithelium of the stomach and intestine, which is of columnar epithelial cells, but whenever there is, as I said, as a result of chronic and persistent GERD, when the squamous epithelial lining of the esophagus is continually and persistently irritated by the acidic contents of the stomach, it will result in diseases like gastroesophageal reflux disorders, and the GERD may lead to the Barrett esophagus, in which there is metaplasia of the squamous epithelium into columnar epithelium of the intestinal type, containing goblet cells secreting mucin. And if cancer occurs in this situation, where the esophageal squamous epithelium is transformed into columnar epithelium, this cancer will be the adenocarcinoma, which is a cancer of the glandular epithelium secreting mucus. So the squamous epithelium and squamous cell carcinoma, which arises in the squamous epithelium of the esophagus, it is common in the upper two-thirds. and this portion is close to the mouth, while the adenocarcinoma, which arises in the glandular epithelium, as I said, that it may be the result of GERD, gastroesophageal reflux disease, in which there is persistent and continuous regurgitation of the uh, acidic gastric contents due to the incompetent lower esophageal reflex or due to high pressure from the abdomen, as occurs during pregnancy, obesity, and other conditions. So sometimes this acid reflux gastroesophageal uh, uh, reflux causes metaplasia in the lower third of the uh, esophagus, and the squamous epithelium is metaplastically transformed into columnar epithelium, and this condition is known as the Barrett esophagus. But if cancer occurs in this type of epithelium, it will be adenocarcinoma, and this type of cancer will be closer to the stomach. Now, we know that squamous cell carcinoma, since it occurs in the upper two-thirds of the esophagus, so as we know that the exact cause of any type of cancer mostly is not known. But in squamous cell carcinoma, the lifestyle factors, for example, smoking, alcohol, drinking, and other conditions that continually damage and irritate the stratified squamous epithelium of the esophagus, they may cause uh, genetic mutations, and the this situation will result in the squamous cell carcinoma. And this type of squamous cell carcinoma is supposed to be close to the mouth. On the other hand, the two major causes of the adenocarcinoma is the GERD, gastroesophageal reflux disorders, and the Barrett esophagus, in which the squamous to columnar metaplasia occurs. Now here a point that I want to mention, that in any stomach cancer, the symptoms, they appear very late. So the symptoms like dysphagia, difficulty in swallowing, adenopagia, painful swallowing, and formation of a mass or thickening esophageal wall, it will be very late when the patient will seek medical advice, when he develops symptoms. So usually this is a very late stage when the disease is diagnosed. And you know that as the disease, when it is diagnosed in a late stage, particularly the cancer, the treatment becomes very difficult and unsuccessful. And for this reason, the cancer of the esophagus, it carries a very poor prognosis. Now, the esophagus, which is lined by the squamous epithelium, as long as the gastroesophageal junction, where the lower esophageal sphincter is located. So at this point, the squamous epithelium joins the columnar gastric epithelium, and this point is known as the gastroesophageal junction. And as we can see in the diagram on the slide, that the squamous cell carcinoma will be the cancer that arises from the squamous epithelium, while adenocarcinoma, it will arise from the glandular epithelium, which consists of columnar epithelial cells and mucus secreting goblet cells. Now, for squamous cell carcinoma, which is supposed to be the most common esophageal cancer in the world, but in the USA, the most common cancer is the adenocarcinoma. So here we talk about the squamous cell carcinoma, which is the most common esophageal cancer worldwide. Now, as we know that the exact cause of cancer is not known, but we know that there are genetic mutations which slowly accumulate and ultimately starting a tissue from mild dysplasia, moderate dysplasia, severe dysplasia, which ultimately goes to anaplasia, and finally it is neoplasia, where the uncontrolled growth and divisions of the cells occur, regardless of the rules, regulations of the cell cycle. And particularly in these situations, in squamous cell carcinoma, the damage to the esophagus occurs from alcohol, cigarette smoke, and sometimes hard fluids that physically damages the esophageal mucosa. So what happens that when the cells in the esophageal mucosa, when they are damaged, either by alcohol, by cigarette smoke, hard fluids, corrosive oils, anything, any disease. So what will happen that these damaged cells which are lost, they will be replaced by the new cells which are formed by repeated divisions of the squamous epithelial cells. Now, when the squamous epithelial cells divide to form new cells and to replace the lost cells due to the, as I said, due to various damages, what will happen that each time the cells divide, each cellular division carries a risk of genetic mutations, particularly in the tumor suppressor gene and the proto-oncogenes. The tumor suppressor gene, if we recall the cell cycle, it will inhibit the mitotic division of the cells, those with mutations in their DNA, right? And they will also push these cells with irreparable damage in their DNA and mutation to apoptic cell death. So once the tumor suppressor genes, that acts like a brake in a car, if it becomes mutated, what will happen that the cells with genetic mutations in the DNA and with damaged DNA, they will continue to divide, and they will not obeying the rules, regulations of the cell cycle. In the similar way, the proto-oncogenes, when they become mutated, normally the proto-oncogenes, they are concerned with the cellular division and they accelerate the cellular division. But once they are mutated, these proto-oncogenes are converted into oncogenes and they allow the uncontrolled cellular division, that will result in changes initially in the form of mild dysplasia, moderate dysplasia, severe dysplasia, anaplasia, and finally neoplasia. So the squamous cell carcinoma is the result of accumulated genetic mutations. The squamous cell carcinoma mostly occurs in the middle third of the esophagus, and initially it starts as squamous dysplasia, and this dysplasia becomes progressive with the newly accumulated genetic mutations, and finally we get carcinoma in situ. But if we say carcinoma in situ if it is limited to the mucosa, but later on if it invades the rest of the wall of the esophagus, or if it invades the surrounding tissue, then we say that this is invasive carcinoma. So what will happen in the picture, you can see the keratin pearls, because the squamous epithelial cells, they have keratin protein in their superficial layers, and in carcinoma, the typical appearance of the squamous cell carcinoma are the keratin pearls, where we can see in this slide is this one. So what happens that a normal cell, when it is converted into a malignant cell, it has its specific characteristics. For example, there is hyperchromatosis, and the nuclear cytoplasmic ratio is changed. The nucleus become larger and the cytoplasm become less. Normally, the nuclear cytoplasm ratio is changed from 1 to 1 into 1 into 6. So the nucleus becomes abnormally enlarged. These nuclei, they are abnormal shaped, and the cytoplasm is scant. And moreover, in progressive cancers, we can see a lot of mitotic figures that are normally not seen in the normal cellular mitotic divisions. So in squamous cell carcinoma, the tumor may either spread within the esophageal wall, and this we say is the diffuse infiltration, or it may accumulate and forming masses that protrude into the lumen of the esophagus, and they can cause obstruction in the esophagus, and dysphagia and adenopagia, and difficulty for the food and finally liquids to pass through the esophagus. Sometimes these tumors become ulcerated, uh, probably because of injury or sometimes because of secondary infections, and form well-defined ulcers. The squamous cell carcinoma will spread initially to the adjacent lymph nodes, but it can spread to the trachea and bronchi, and uh, in that situation they form a fistula. When the tumor spreads to the trachea or major bronchi, so what happens that they perforate the trachea and or the a major bronchus, and in this situation they will form a fistula, and in which contents of the esophagus may go into the trachea and lungs and may produce serious conditions like dyspnea, cough, and other problems related to the respiratory system. Sometimes the tumor may invade the aorta, which is close, particularly the aortic arch, which is close to the middle contraction that is present in the esophagus. So, aortic arch, which lies in front of the esophagus, if a tumor is near to that region, and if it invades the aorta, serious complications and a catastrophe may occur. The tumor may also spread to the mediastinum, and sometimes it may involve the membranes of the heart, the pericardium. Now, coming to the adenocarcinoma, we know that what happens in adenocarcinoma, the two major risk factors are the GERD, gastroesophageal reflux disorder, and the Barrett esophagus. So, what is the Barrett esophagus? When the lower esophageal sphincter is incompetent. By that, uh, we mean that it doesn't close as it normally does when the food passes from the esophagus into the stomach. So, what will happen that in the incompetent lower esophageal sphincter will allow the gastric contents which are acidic to regurgitate into the esophagus, and what will happen that this continuous regurgitation of the acidic gastric contents, they will damage the squamous epithelium, and in the response the squamous epithelium, it will undergo metaplasia into intestinal type of columnar epithelial cells. And we know that what is metaplasia? Metaplasia is a type of adaptation. Other adaptations are hypertrophy, atrophy, hyperplasia. So metaplasia is a reversible adaptation in which one adult type of epithelium is replaced by another adult type. So in esophagus, what happens that there is squamous epithelium replaced by columnar epithelium of the intestinal type. And this is known as the intestinal metaplasia of the squamous epithelium. Similar examples of metaplasia we can see, for example, in the upper respiratory tract when the metaplasia occurs on the reverse side, in which the columnar epithelial cells, they are replaced by squamous epithelial cells in people, for example, heavy smokers, when they continually, habitually do have smoking, the contents of the smoke, they will damage the cells, columnar epithelial cells of the upper respiratory tract, and they will undergo metaplasia into squamous type of epithelium. Here, what happens that the chronic irritation which is caused by the chronic and persistent GERD, mainly because of increased pressure from the abdomen or incompetent lower esophageal sphincter. What will happen that the acidic gastric contents, they will continually irritate and damage the squamous epithelium, and as a result the squamous epithelium will undergo metaplasia into the intestinal type of columnar epithelium. So in this picture we can see that this is the uh, squamous epithelium, but in this area the squamous epithelium has undergone metaplasia, and the red velvety mucosal patches of the metaplastic mucosa can be seen. This is the uh, light brown columnar gastric mucosa. So what happens that once Barrett esophagus occurs, it carries a high risk of adenocarcinoma, because there is the glandular tissue columnar type of intestinal cells. So the cancer that occurs in this situation, it will be the adenocarcinoma. But here one thing that I want to mention, that not each and every patient with Barrett esophagus will develop adenocarcinoma, but the risk here is increased. And what happens that in the metaplastic cells there is progressive dysplasia, mild, moderate, severe, and this will lead to anaplasia where there is complete loss of structural and functional differentiation, and it will result to the formation of neoplastic cells and adenocarcinoma. So adenocarcinoma is most common in the distal third of the esophagus, and mostly the upper part of the stomach known as the cardia, which is continues upward with the esophagus. So initially the Barrett metaplasia, it is non-dysplastic, but slowly and gradually dysplasia occurs in the metaplastic epithelium, and as a result there is stepwise accumulation of genetic and epigenetic changes, particularly chromosomal abnormalities and mutations in the tumor suppressor gene, T53 genes, and the proto-oncogenes. Initially, morphologically, the adenocarcinoma, it forms early lesions which are flat and sometimes form small raised masses, raised patches, but here the mucosa is intact. But later on, when as the tumor grows, it may form exopatic masses. Exopatic, by exopatic means we mean that masses that protrude from the esophageal wall towards the lumen, and they also may diffuse and infiltrate the esophageal wall, and these masses sometimes ulcerate, and uh, as we know that when an ulcer is formed, it will extend deep through the esophageal wall, and uh, as we know that these are columnar epithelial cells containing goblet cells, so these tumors, they will form glands and they will produce mucin. Now the risk factors, the smoking and age more than 60 years and achalasia. These three are the risk factors for both of the esophageal cancers. The risk factors we can say modifiable and non-modifiable. For example, smoking is a modifiable risk factor. We can advise the person to quit smoking so we can stop it. But the age, it is non-modifiable risk factor, because we cannot increase or decrease the age of a person, and most commonly these tumors occur in the advanced age when the age is more than 60 years. Achalasia is a condition in which what happens that the lower esophageal sphincter, it is closed or nearly closed. So what happens that the food cannot easily pass from the esophagus into the stomach, and automatically the food, it will accumulate in the esophagus, forming the mega esophagus, and this presence of food in the esophageal lumen persistently is a risk factor for the esophageal cancer. Now, specific risk factors for squamous cell carcinoma are the alcohol consumption, heart fluids, and caustic structures, for example, the house bleach and other corrosive oils and alkalis, if they are taken accidentally, they can cause um, irritation and inflammation in the mucosa of the esophagus, and later on can result uh, in persistent irritation. By these risk factors may cause uh, the development of the squamous cell carcinoma. Plummer-Vinson syndrome is a condition which is mostly associated with some type of nutritional problems or nutritional deficiency, and in addition to dysphagia with difficulty in swallowing, the Plummer-Vinson syndrome is also associated with glossitis, by which we mean inflammation of the tongue. It is also associated with iron deficiency anemia, and also there may be chelosis or cracking at the corners of the mouth, and it is also a risk factor for the squamous cell carcinoma. For adenocarcinoma, the two major risk factors which are of major concern are the chronic gastroesophageal reflux disorder, also known as the GERD, and the Barrett esophagus, in which the squamous epithelium of the esophagus undergo metaplasia, and as a result of the metaplasia, it is converted into uh, columnar epithelium of the intestinal type containing goblet mucus-secreting cells, and this situation is known as the Barrett esophagus. Now, most of the tumors of the esophagus, they are initially asymptomatic, and the patient has no symptoms. And this is unfortunately this loss of symptoms, and uh, when the patient, that the patient will seek, mostly in our country there is no routine checkups, and the patient will seek medical advice only when he develops symptoms. And in esophageal cancers, when the patient develops dysphagia, adenopagia, or chest pain, then he seek the medical advice. And by the time when the doctor knows that the patient is having uh, esophageal cancer, and at that time when it is diagnosed, it is very late, and most of the time the cancer has spread to the distant organs, and it has undergone local invasion, and we know that then the treatment becomes difficult and problematic. Now, with progression of the most, when the disease progresses more, uh, what happens that first the patient develops dysphagia, difficulty in swallowing foods. Initially, the patient suffers from difficulty in swallowing solids, and long times after, then the patient develops difficulty in swallowing even liquids, and this is a very dangerous sign, and by this we can say that the cancer has spread a lot, and it has caused narrowing of the esophagus, and therefore this patient, uh, initially when he was having difficulty for swallowing the solids, now it is difficult for the patient to swallow liquids, and mostly this is a late stage. The pain in the chest or back, and it may sometimes be mistaken for pain due to ischemic heart disease. Automatically the patient will suffer from vomiting, and this situation overall will lead to severe weight loss. And if the cancer perforates the trachea, which is nearby in front of the esophagus, what will happen that it will form a communication or a fistula, and which can cause pulmonary aspiration of the esophageal contents, and when the esophageal contents are aspirated into the trachea and lungs, they will cause symptoms like cough and dyspnea. Now, sometimes the cancer may uh, invade the diaphragm inferiorly, and in this situation the patient develops severe hiccups, and which are very difficult to be relieved. Now, for the diagnosis of esophageal cancer, what we can do to take an endoscope and to see the inside of the esophagus, and if we see a tumor or a mass, or a lesion, we can take a biopsy and we will send this biopsy to the histopathology lab, and from there we may get a confirmed diagnosis that either it is the normal squamous epithelium of the esophagus or it contains neoplastic cells, tumorous cells. And at the same time, we must do endoscopy of the larynx, trachea, and bronchi, because sometimes tumors also uh, are present in the larynx, trachea, and bronchi, and the reason for this is that all these tumors of the esophagus, larynx, trachea, and bronchi, they all share the same risk factors. For example, the smoking, alcohol, obesity, and other risk factors. So during the endoscopy, we must also see the larynx, trachea, and the bronchi. Now, computer tomography of the chest will evaluate the involvement of the nearby lymph nodes. Uh, we can see that either the cancer has metastasized to the nearby lymph nodes or not. Now, X-rays with barium contrast. What we do that barium meal or barium swallow, which is a contrast medium, and that we can say on X-ray. So we advise the patient to swallow the barium, and at this time we take an X-ray of the upper gastrointestinal tract when the patient is swallowing the barium, and we will see in our X-ray the location of the cancer, and sometimes we can also see the complications of the ulcer in the form of ulcers and esophageal stenosis. If it has got narrowing of the esophagus or esophageal stenosis, so it may be evident in the barium swallow imaging techniques. Positron emission tomography, known as the PET. Positron emission tomography is a procedure, and uh, by using the positron emission tomography, we may also see that either the cancer has metastasized, and we can also evaluate the response to chemotherapy. If we are doing chemotherapy, the positron emission tomography can tell us that either the tumor has decreased in size or not. So we can use this procedure to see the effects of the chemotherapy. In this picture, we can see that this is a chest CT, and we can see that the cancer is visible in the lymph node. In the barium swallow, we can see the narrowing of the esophagus and the presence of ulcers. And the positron emission tomography can tell us that the size of the tumor with chemotherapy is decreasing or not. So it can tell us that how much successful we are in treating the esophageal cancer. Now we divide the esophageal cancer, we stage the esophageal cancer through the TNM staging. The TNM staging is a parameter we use for staging the esophageal cancer. By T means the tumor size and its local extension. So the T, we divide the T into T0, T1, T2, T3, and T4. And as the number increases from T0 to T4, the tumor size is increased and it becomes locally invasive. By end, we mean the lymph node metastasis. If either the tumor has metastasized into the lymph node or not. So according to the involvement of the lymph nodes, we divide this into N0, N1, N2, and N3. While the M means distant metastasis to the distant organs. So it can be either no distant metastasis M0 or presence of distant metastasis. For example, if we see that a tumor is T1, N0, M0. So by this we mean that the tumor size is not much more. If it was T2, T3, T4, so it would be more increased size. N is 0, there is no metastasis to the lymph nodes. and M is 0, there is no metastasis to the distant organs. So we label this as in stage 1. But if the M, which is the distant metastasis, if it is 1, even 1, so at this stage we don't think about the T and N. But if distant metastasis is present, we will stage this esophageal tumor as esophageal tumor stage 4. And as the stage increases, the prognosis becomes more and more poor, and the treatment becomes more and more difficult. In the initial stages, we treat these tumors when it is limited to the mucosa and sometimes to the submucosa, so we can surgically remove the esophagus. We can also do the endoscopic tumor resection. This depends on the patient and the decision of the surgeon, that either he removes the total esophagus, or if he considers that if the tumor is endoscopically removed, uh, whatever so is appropriate. And sometimes we can do mucosal ablation. And in the mucosal ablation, what we do, that we remove the cancerous mucosa by using the radio frequency. So by radio frequency, we try to remove the cancerous mucosa. Now, once the tumor has metastasized to the distant organs and it is advanced, then we are left with no option other than chemoradiotherapy and surgery. And mostly the chemotherapy, radiation therapy, and surgery, they are used in various combinations as is appropriate for the patient. Once we come to know that now the cancer is incurable, there are distant mets present, so we can help those patients by the palliative treatment. And one of the way in which we treat the patient, that we put in small esophageal stent, which is a tube-like structure, and we put this tube inside the esophagus, and we artificially we make the esophagus dilated, and this procedure, which is a sort of palliative treatment, may help the patient with dysphagia and adonophagia. So this is the summary. Esophageal cancer, uncontrolled growth of esophageal epithelial cells. Risk factors for both smoking, age, and achalasia, in which the lower esophageal sphincter is tightly closed and food is not allowed to pass into the stomach, so it will accumulate in the esophagus, causing the megaesophagus. Two types of cancer: squamous cell carcinoma from stratified squamous epithelium, and it has got its some specific risk factors like alcohol, heart fluids, and uh, accidental suppose inhalation of the corrosive oils, alkalis, and other chemicals like bleach, and which can cause caustic structures, and the Plummer-Vinson syndrome, which is a nutrition related disorder in which glossitis, inflammation of the tongue, and chillosis, cracking at the corners of the mouth, iron deficiency anemia, and esophageal webs. These are also seen in the Plummer-Vinson syndrome, and this is a very important risk factor for esophageal cancer, particularly the squamous cell carcinoma of the esophagus. And the palmoplantar keratoderma is a condition in which what happens, that there is keratosis, excess formation of thick keratinized epithelium on the hands and feet, and uh, the exact cause of this type of uh, palmoplantar keratoderma or keratosis, it is also a risk factor for the uh, squamous epithelial cell carcinoma. Adenocarcinoma, which arises in the columnar epithelium, and the two major risk factors are the GERD and Barrett esophagus. So GERD, Barrett esophagus, and adenocarcinoma, they are closely related. GERD causes Barrett esophagus, and Barrett esophagus is a risk factor for the adenocarcinoma. Commonly, the symptoms are dysphagia, adenopagia, vomiting, and chest pain. Diagnosis is made by endoscopy and biopsy, and chest CT, barium contrast, X-rays of the upper gastrointestinal tract, and positron emission tomography are used during the course of the disease to evaluate the response to the therapy and the aggressiveness of the tumor, and either the tumor is responding to the chemotherapy or not, or in otherwise it has made a complication in the form of an ulcer or stenosis or not. And treatment, as we discussed, is depends on the stage of the tumor. If limited to mucosa and submucosa, so surgical removal of the esophagus or removal of the or ablation of the mucosa may be sufficient, and sometimes endoscopic removal of the tumor may be sufficient. But once the tumor has advanced and it has given to distant metastasis, then we are left with no option other than the chemotherapy, radiation, surgery as if it is appropriate, and the palliative treatment that we can give to the patient. Thank you very much.